Thank you, Eric. Well, thank you again for the invitation to present. And I'm here in London with our first full-time cardio-oncology fellow, Dr. Nilesh Parikh, who actually joined us last October. So he's already now well into the second half of his year fellowship with us. And we've deliberately picked a different condition and a different problem from the last cases. But this has been a very challenging case for us to really get to the bottom of, as we'll see as we go through. And again, we've tried to make it interactive, so at several points we'll be asking the audience for their views and what they might consider along the way. And of course, as always, there aren't any right or wrong answers in some of these difficult cases. So handing over to Nilesh.
Thank you, Alex. It's a great pleasure to present this case, which we've entitled, "If it quacks and looks like a duck, what is it?" The case pertains to a 68-year-old gentleman with a background history of low-grade small cell lymphocytic lymphoma, initially presenting with ascites. He went on to have surgical laparoscopy, which confirmed retroperitoneal lymph nodes and peritoneal streaking, and subsequent biopsy confirmed small cell lymphocytic lymphoma. He was treated with chlorambucil for 3 months from August to November 2012, and there was no significant ascites on a follow-up scan, and so the chemotherapy was held at that point. He had a background history of previous thyrotoxicosis with radioiodine treatment, permanent atrial fibrillation for over 10 years, for which he was taking warfarin, and orally treated type 2 diabetes mellitus. In February 2013, he was referred to the cardio-oncology service at the Royal Brompton Hospital by his haematology team. He gave a history of a 12 to 18-month history of recurrent ascites and peripheral edema, which is not in keeping with the extent of his low-grade lymphoma. He also had significant dyspnea on exertion and was NYHA class 3. There was no significant chest pain, palpitations, or syncope. Blood test showed a mild anemia with a hemoglobin of 11.6, a normal creatinine of 90 micromoles per litre, but a raised BMP at 144, and a polyclonal increase in his immunoglobulins, but no paraprotein was detected. A chest X-ray, shown on the right, confirmed cardiomegaly with probable biatrial enlargement, but no evidence of alveolar or interstitial edema. His ECG showed rate-controlled atrial fibrillation with a narrow QRS complex, some non-specific lateral T-wave flattening, and possibly small complex QRS complexes in the limb leads. Although this was in the setting of a gentleman who was a big chap with significant adipose tissue. We proceeded to perform transthoracic echocardiography, and this confirmed him to be an atrial fibrillation with a normal cavity size and normal ejection fraction, as shown in the top left panel. His apical four-chamber confirmed a septal bounce with normal ejection fraction and significant biatrial dilatation. There was also no significant pericardial effusion, but we also noted reduced long-axis function. Although he was in atrial fibrillation, we felt that he had a restrictive filling to his E-wave with a rapid deceleration slope. And although it's difficult to interpret in atrial fibrillation, there may have been respiratory variation, significant respiratory variation of the mitral inflow. Interestingly, he also had accentuation of his hepatic vein flow in systole and diastolic flow reversal on inspiration. We proceeded to perform cardiac MRI, and this concurred with the findings on echocardiography. We found him to have a normal ejection fraction with normal LV wall thickness, no significant pericardial effusion, but reduced long-axis function. He also had significant biatrial dilatation on both scans, and we were mindful of his long history of atrial fibrillation, and while there was a slight increase, this was probably not a significant increase between the two scans. We were struck by by the lack of significant late gadolinium enhancement with a very small amount of RV insertion point fibrosis, an area of mid-wall septal late gadolinium enhancement, and possible infralateral wall also. We also performed a Look-Locker T inversion sequence showing the gadolinium kinetics, starting on the top left panel and continuing all the way down to the bottom right. And you can see that there is a significant nulling of the blood pool within the left ventricular cavity first, and then subsequently nulling of the myocardial trace. And to give you a context, this fits in more with normal kinetics. As you can see in the top left, you can see that there's initial nulling of the left ventricular blood pool and then the myocardium, which is different to the pattern seen in amyloid, which is opposite, with nulling of the myocardium first and subsequently then the left ventricular cavity. We also performed a myocardial perfusion scan in view of his diabetes to ensure there was no element of ischemia, and this confirmed preserved left ventricular systolic function, but with fixed reduction of counts in the mid-anterior and mid-inferior walls. This was felt to be representative of a myopathic process as opposed to ischemia or infarction. So at this point, I'd like to put it out to the audience about what they feel the differential diagnosis would be, and also regarding any future investigations or management plans they would suggest.
So to summarize, he's a 68-year-old gentleman. He's got this chronic small cell lymphocytic lymphoma. The hematologists have given him one sort of treatment round of chlorambucil, but actually in discussions continuously said it was very low grade and it didn't merit any active treatment. And then he has presented to us with a story of recurrent ascites. That's certainly a transudate when it's been drained elsewhere, and then you've seen the various cardiac imaging with certainly an element of restrictive physiology, significant biatrial dilatation in the context of long-standing atrial fibrillation, but with significantly reduced long axis function and also the septal bounce. But on MRI, no evidence of active pericardial pathology. The pericardium appeared normal in appearance, and there was no sort of compliant, and also with the late gadolinium enhancement, there was really no significant suggestion of myocardial fibrosis, and finally a normal amyloid sequence on the cardiac MRI.
So this is Dan. I didn't hear the beginning. Sorry, I didn't catch on at the very start. But were there any significant lab abnormality?
So yes, sorry, Dan, in the summary I didn't mention. So essentially he has preserved renal function given his size, because he's a big chap, and with his background of diabetes, he has an elevated BNP, so it's 144, where our normal range in our lab is less than 20. And he has polyclonal antibody increase, but no paraprotein.
And troponin was negative?
Troponin was normal, yes.
And then in terms of his other labs, there wasn't any major findings to speak of? Or?
No, so we haven't deliberately omitted something to hold back. So there was nothing else was significant. Liver function was fine. He does enjoy a drink, and his gamma GT was up a bit, but that was in isolation. And as I say, the hematologists, when they'd done the previous bone marrow, felt that his level of his lymphoma burden was so low that they wouldn't be actively treating it, that they would monitor it. And his hemoglobin was slightly at the lower end of normal for a man at 11.4, or below normal, but with preserved white cell count and platelet count. And clotting profile was obviously influenced by the fact he's on warfarin.
And no protein in his urine?
No protein in the urine. And that includes a 24-hour urine protein, which was normal, and no Bence-Jones protein detected.
Did you guys mention before what his ferritin was?
We didn't. Let me go and look that up because we've got his computer at his labs, but I don't recall it being elevated. There was a period when, subsequent to our initial assessments, where he was getting a few nosebleeds. So we've got to be careful that the ferritin wasn't reduced in that context. Okay. If anyone want to fire out any differential, either regular cardiology or within the context of cardio-oncology?
Yeah, this is a challenge. I would say, you know, you've done all the basic evaluation to make sure there's no amyloid present, and if you had a high degree of suspicion, then you know you probably would have to biopsy him. But that's you know, so but
we would say that the myocardium, I've deliberately left the MRI up, that it doesn't look as though it's particularly thickened, and it thickens normally, at least in the radial axis. Obviously, long axis is reduced, but then he's in long-standing atrial fibrillation. So maybe I'll hand back to Nilesh, unless anyone else has any more comments to continue.
Alex, I was going to ask you, what troponin do you use there in London?
So we use troponin I, and that's a very important question to ask. So we use what is termed a regular assay, and therefore the normal range is up to 40, and up till about 2 years ago, anything was below 40 was reported as less than 40. But now, and that's nanograms per liter, but now they give us quantification in the range of 20 to 40. So that's starting to get into the high sensitivity range. But at the hospital, we don't actually formally use a high sensitivity troponin assay. I can talk about the politics of why that is if anyone's interested, but maybe at the end of this.
Thank you, Alex.
But we don't.
Great, so we had similar thoughts, and in view of the mixed possible constrictive or restrictive physiology, we thought constrictive pericarditis was a possibility, or indeed a restrictive cardiomyopathy potentially related to cardiac amyloid, despite the findings on the cardiac MRI. And if those two were not possible diagnoses, potentially a true HFpEF pattern secondary to chronic AF or diabetes mellitus. Our first plan was to reduce his peripheral edema, and we commenced bumetanide 2 mg BD, performed a cardiac CT to rule out any significant pericardial abnormalities, though this wasn't seen on the MRI scan. Perform a right and left cardiac catheterization and an SAP scan to further exclude a diagnosis of cardiac amyloid.
An SAP scan is?
So it's a serum amyloid protein scan, which is a nuclear medicine scan assessing for amyloid deposits throughout the body, so including cardiac and also renal.
Is that like a pyrophosphate type scan?
And it's done in the context, Dan, and for everybody, that actually this is performed by our National Amyloid Centre. And I felt, because he's got this low-grade lymphoma, he's got heart failure with some suggestions that it could be a restrictive cardiomyopathy, that we should have him formally evaluated by the National Amyloid Centre and included in their protocol as the FAP scan, because if they find amyloid elsewhere, it's equally diagnostic in terms of end organ evidence of end organ injury. But obviously we were specifically asking them about cardiac amyloid.
Yeah, so in the United States, you can get a pyrophosphate scan, which is sort of similar, I think. I don't know.
We'll show you what they did in a minute. Okay.
Okay, sounds good.
Okay. Yep. So I'll go on to just show the investigations that we performed at the Brompton and then at the National Amyloid Centre. So the CT chest was reassuring and did not show any pericardial calcification or any stiff compliant pericardium.
Yes. Normal thickness and no evidence to suggest pericardial effusion, which we also note from the echo and the MRI.
But we then went on to perform a right heart catheterization here at the Brompton, which was interesting. And on the left panel, you can see the simultaneous left and right ventricular pressures. The first striking feature is that both the LV EDP and the RV EDP are significantly raised at 20 and 18 respectively. The second notable feature is this very classical dip and plateau phenomenon, suggestive of rapid diastolic filling of the ventricles. This would also suggest constricted filling, since the right ventricular end diastolic pressure was greater than the third in comparison with the peak right ventricular systolic pressure. This, furthermore, the fact that there was less than 5 millimeters of mercury difference between the left ventricular end systolic pressure and right ventricular end systolic pressure pointed towards a possible constrictive physiology. Interestingly, he had a raised capillary wedge pressure at 26 millimeters of mercury, and also pulmonary hypertension with a mean PA pressure of 29 millimeters of mercury. He also went on to have a saline challenge during the right heart catheterization, which showed two things. The first was that there was no increase in the difference between the LV and RV EDP, pointing more towards a constrictive physiology. But going against that was the relative concordance of both pressures, which may be more in keeping with a restrictive physiology.
You know, that's like one of those things that the day before you take boards, and unfortunately I have to take boards again in October, is I have to review sensitivity and specificity and what that means, and then the other thing is the hemodynamic differences between constriction and restriction, because I'm guaranteed to get them confused without reading them 2 seconds before.
I think I can comment from this side of the pond and say you're not the only cardiologist who finds this very challenging to remember. And superimposed on that in this case is the fact this chap's in atrial fibrillation, so quite a few of the elements of information that are helpful to differentiate the two you can't use. So I think my conclusion when I first saw this was that this confirms that he has either constrictive or restrictive physiology, and that would be very consistent with his clinical picture of recurrent ascites, but I don't think it defines which one, so it still keeps it open, but it is diagnostic that there is a problem going on. And we've seen reduced long axis function on his echo and MRI, so that would be in keeping with restrictive physiology, and we haven't seen any overt abnormalities of his pericardium to sort of drive us towards constriction, and he hasn't had any radiation to the chest or other autoimmune diseases where you might be considering constriction as a likely cause, but I think the diagnosis is still open at this point. Happy to hear any other cardiologists or even oncologists interested in right and left pressure catheterization.
I think it's beautiful that you showed them.
So with that information, we then referred the patient to our National Amyloid Centre, which is based in London, and they performed a DPD scan, which is shown on the left, and also the SAP scan, which we were discussing earlier. The DPD scan did not show any signs of cardiac involvement, and the SAP scan also did not show any evidence of amyloid deposition within the heart or, in fact, within any viscera.
He does look like a big chap, as you say.
Yes.
I just wanted to go through the other findings from the National Amyloid Centre. So we mentioned the fact that there was no proteinuria, indeed, on 24-hour urine collection. They also confirmed the polyclonal increase in the antibodies, but no serum paraprotein. And there was a mildly raised kappa light chain with a slight increase in the kappa lambda ratio. But overall, the National Amyloid Centre's conclusion was there was no evidence of cardiac amyloidosis. At this point, the hematologist also performed a repeat bone marrow biopsy, which confirmed 7% malignant cells, but was felt to be low grade. And the advice at that point was for observation and no further chemotherapy treatment at that point. So at this point, we'd like to put it back out to the audience about what they feel would be the next important investigation or any other thoughts.
Was this man hypertensive? I don't remember if you alluded to that before.
No, he's never had hypertension, but he did have diabetes.
It's interesting, the test you did for amyloid there in terms of scanning, because those are scintigraphy studies, iodinated compounds with for amyloid, and in this country we've been using 3 isotopes that have been approved that are PET imaging for amyloid, and of course we're looking for amyloid of the brain, but we've been using PET imaging quite a bit, and of course if it's negative, then you rule that out. If it's positive, it depends on the age of the patient and how much.
Okay. So at the moment, just to remind you, we're managing this gentleman with loop diuretics, and in fact I needed the combination of loop and a thiazide for sequential nephron blockade in order to really control his fluid balance, and we got him back to actually a relatively stable phase of his sort of clinical status, to a point, to give you a context, where I got him back on the golf course, which was viewed as a success from his perspective, but we were still sort of conscious that he was behaving possibly like a restrictive cardiomyopathy without us really getting to the bottom of it, although this could well be the influence of chronic atrial fibrillation plus some type 2 diabetes. He's obese, his cholesterol, his HDL was slightly low, but with a normal perfusion scan I hadn't wanted to muddy the waters by giving him any therapy for that at this point.
Right, so his AFib was long-standing, so you couldn't potentially address that, but...
Yeah, well, yeah, we didn't think that it was he wouldn't have been a good candidate for an ablation.
Yeah, okay. Yeah, I don't know. This is one of those really difficult situations, and you know how to manage this patient because you're not really sure what the cause of his restriction or constriction is, and then if you don't even really know what the cause is, then it's hard to direct any therapy at it.
I agree. Should we let Nilesh go on then? Okay.
So, as we alluded to earlier, we did indeed proceed to right ventricular endomyocardial biopsy to obtain some tissues in order to understand the pathophysiological process in more detail. And this showed that he had reactive cardiac myocytes with evidence of interstitial fibrosis confirmed both on H&E staining and elastin Van Giesen staining. And we then also performed Congo red stain on that, and that was also negative, fitting in with the CMR findings as well as the SAP scan performed at the National Amyloid Center. Our conclusion was that this was indeed a myopathic process at this point, but again, not in keeping with true cardiac amyloidosis.
So that's interesting. It would be interesting to see if we did a Molly scan with MRI, and if we could pick up how much fibrosis there was.
When you say a Molly, is that a T1 sequence?
I think it is.
Yeah, so we're very sort of familiar. The Brompton are very interested in this as a leading cardiac MRI centre in terms of the role of T1. And actually, I think the other centres in the world have shown that amyloid is probably the best example in the infusion gated protocol of it. However, I think we would, certainly in this centre, we feel it's still in the research domain rather than in a clinically proven sort of domain to guide treatment. But having got a biopsy showing expansion of the extracellular space, in some ways you'd see this, the T1 would be, it would be using it to confirm the role of T1.
Yeah, I think that, well, you've done a very extensive evaluation and I'm not sure that you have a clear idea where to go at this point.
Okay. So can I just put it out to the audience? Is there anything else anyone would like to do to check? Because at the moment, I'm sitting with this patient, if I roll the clock back 12 to 18 months to say, right, well, we've just looked in extensive detail to see if there's any evidence of a problem relating your lymphoma to your heart, and we're really coming out with lots of normal results. Your heart isn't normal, but you've had lots of other issues going on that might explain that. Is that a reasonable summary?
Yeah.
Now, I should say, therefore, oh, sorry, is there anyone else?
Yeah, I was going to suggest if he had responded a couple of years ago to the chlorambucil, was there a consideration maybe to start that again? I know that the cell count was low, but there was a response 2 years ago.
So along this journey of investigations, I kept obviously in close dialogue with the hematologist with my clinical view that his lymphoma was in some way causing this problem of his heart, and that I'd be very suspicious and that we should have a low threshold for treating the lymphoma. However, each time I went back, the hematologist said, look, well, we wouldn't consider any more intensive chemotherapy targeting the lymphoma unless we had evidence that there was a problem. And you can see the evidence I've tried to obtain that kept on not providing that answer. But I agree, sitting in the cardiology clinic, I was thinking, I'm really suspicious this is being driven by his low-grade lymphoma, but we can't prove it to a level that would, say that the benefit of further chemotherapy outweighs the risks.
Okay.
But I take your point completely. Okay, so at this point, fortunately, we'd had a conversation with our colleagues at the National Amyloid Centre about this, obviously, so we brought them into this sort of multidisciplinary discussion, and we felt that there was one further test that we could do. And that was that when we performed the endomyocardial biopsy, that we should take some samples in glutaraldehyde for electron microscopy. So I'm going to hand back to Nilesh.
So this slide shows the electron microscopy, which in fact made the diagnosis. And on the left, you can see myocytes on the left, the extracellular space in vision at a magnification of over 29,000, and this showed expansion of the extracellular space. And when we zoom down on that with a magnification of 128,000, you can see these small circular black lesions, which were confirmed to be granular deposits, which were felt to be consistent with light chain deposition disease. So we made a diagnosis of end organ light chain deposition disease related to the gentleman's small cell lymphocytic lymphoma. At this point, we contacted the hematologists, and it was felt that, it was sort of in line with the conversation we just had, that chemotherapy was now indicated. He was treated with melphalan induction and then rituximab, with initial excellent hematological response, albeit the treatments requiring a significant fluid treatment with over 2 litres per cycle. From a cardiology point of view, we added spironolactone, which initially caused gynecomastia, so we switched to a pleuronome, and he did have increasing diuretic requirements up to bumetanide 4-BD, and also added benzoflumethiazide. He's recently had one admission with decompensation of heart failure requiring intravenous diuretics, but overall continues to make a good symptomatic response, which is paralleled by an improvement in his BMP. So light chain deposition disease is a rare monoclonal multi-organ deposition disease of amyloid light chains. It's associated with a monoclonal plasma cell expansion with mainly kappa chain overproduction. It has a male predominance, and renal involvement is with rapid deterioration of renal function is a common feature, which we didn't see in this patient. The gold standard is histology exhibiting kappa fixation along the tubular basement membrane. But interestingly, in parallel with this case, it's usually Congo red stain negative, serum amyloid protein scan negative, and also CMR negative. It's associated with multiple myeloma and also with lymphoma variants. Serum plasma electrophoresis, immunofixation electrophoresis, and quantitative serum assays can be helpful diagnostically, and the median survival is 4 years. Poor prognostic features include age, presence of multiple myeloma, and extrarenal involvement. Treatment can vary from autologous stem cell transplantation to bertozumab and other immunomodulatory drugs such as thalidomide or rituximab. So, as we sort of alluded to at the beginning of the case, this case really was a case of if it quacks like a duck and looks like a duck, it's not a duck. But we're mindful, especially at the moment where it's England versus Australia in the Ashes tournament for the cricket, that occasionally this can be a duck-billed platypus.
Yeah, this is quite a case. But, you know, so it's curious that that they chose to treat with mephilan and then Rituxan. If you really felt that this was light chain deposition disease, which from your EM, that's what it certainly looks like, why you wouldn't use Velcade or thalidomide and pomalidomide and all that.
Yes, I mean, that goes back into the hematologist space to say, well, he felt that there was a very high chance of effective cure or complete remission of the cell-based pathophysiology using that drug combination. And in fact, due to the particular phenotype of the lymphoma, he's now also considering another targeted molecular therapy for it, which is ibrutinib, because the subform of the lymphoma, based on its CD status, which unfortunately I don't have immediately available, says he's a potential candidate for this. So the hematologist feels he has a very good prognosis from the hematological perspective. The challenging issue is he's currently got restrictive cardiomyopathy, and we're still sort of trying to see how that will define his cardiac prognosis.
Yeah, well, that's a really fantastic case, and I really appreciate all the investigations that you showed us, because those are really cool.
You know, I think the other question I have is, you know, we're at an academic center where we obviously send multiple endomyocardial biopsies for amyloid, and I'm always disappointed when it's negative, because then I'm left with a patient with restrictive cardiomyopathy and I don't have an explanation. I sort of now wonder, should I be looking further? Should I be sending it to sort of a quote-unquote amyloid center to look more deeply like you guys did, because maybe we're missing this more than we think we're missing it?
I think this case in a way highlights that for me, and I expect for many people listening, in that I just was convinced as he came back with recurrent ascites that this was a restrictive cardiomyopathy, and we do treat lots of people with long-standing diabetes and atrial fibrillation, and they don't typically present with recurrent ascites. There's obviously a few that might do, but in the absence. So this is really behaving like a constrictive or a restrictive cardiomyopathy. He's got a low-grade lymphoma, and you just think there must be a link here. So hence we just sort of pursued it. But I think that maybe one of the educational messages is, when you're doing the endomyocardial biopsies for any patients, always take one sample for the glutaraldehydes, so that you can at least have the option later down the line to do EM if you have the option, or you can send it to a center which can do it if you haven't got the answer on regular histology.
Yeah, I mean, I think that's a good point. We had a case recently that, so we like to think of ourselves as an amyloid center too, but I can still say that it's a challenge. It's a challenge in very many ways to kind of go through the details of some of these patients. But so we had an example of it's like a 55-year-old man that had 3 family members that died at a young age from heart failure, and one of them was told that he had, or one of the family members, I think it was his mother, was told that they thought she had amyloid when she died. So that was his family history. And then we had a genetic marker, one of the TTR genetic abnormalities, I can't remember which one, like Val 122 or something like that. So the patient had the genetic marker, and he had a very positive family history that was quite strong in terms of amyloid. And he has had, over the course of 6 years, he's had 3 biopsies, myocardial biopsies. The first one, they felt like an insufficient sample. Second one, read as negative by H&E staining for Congo red. And then did this third biopsy just recently, where because his LV function was pretty significantly depressed now, ZF was 25, he was quite symptomatic from heart failure, and he had no other medical conditions to speak of. Pretty much he just had this genetic abnormality for TTR, family history that was very positive, and we couldn't prove cardiac amyloid, and we wanted to try to get him in a trial for that. And the requirement for the trial is that you had to have biopsy proven cardiac amyloid. So did the biopsy, H&E stain was negative, sent it for EM here, and they said no clear evidence of amyloid, just some fibrosis. And we actually sent the sample to Mayo to have them look at it too, and they basically said more or less the same thing. So, but the problem is that, it's kind of like you said, in this case, you had this low-grade lymphoma, and you had a significant restrictive cardiomyopathy, and how those things, it seems like they should be linked. And in this case, you have a genetic abnormality, you have worsening heart failure. It seems like those are connected, and we haven't proven that. So I don't know if the processing that you did for EM, if there was some way that it was done, that we should probably take a lesson from that and see if we should redo the EM in this particular patient.
Yeah, well, I can certainly get the methods, because it wasn't our centre that performed it, Dan. So I'll need to, I can chase up the methods for you and for anyone so that that's available. But it sort of partly was a lesson in trusting your clinical view, as you say, because you want to, I suppose your challenge is what the treatment pathway for your patient is in a research trial with inclusion and exclusion criteria.
Yeah.
If you had a drug that was licensed for TTR amyloid, you'd probably just put them on it.
Exactly. Yeah, I definitely would. I mean, but anyway, no, it's a really super case, and thank you so much for doing it.
Oh, Alex,
does anyone else have any questions?
Yes, Alex, that's a great case, and we would like you to submit that to Onc Review, because that would be a wonderful case for our readership.
Yeah, and I think.
Yes.
Yeah, I mean, it's. I mean, you just have beautiful images, and you went through a very disciplined process to figure it out. It's quite good.
Well, Alex, yeah. I thought it was a platypus from the beginning, Alex.
I think the point is also the one on the left is very common and the one on the right is very rare. But they both look similar if you're just looking at the front half of them.
So do they have the platypus in the Thames River, or?
Oh no, I'm not sure if anywhere has it outside Australia.
Well, I didn't know. Maybe if you looked really hard, you'd find it.
Yes.
Once again, if you hear hoof beats, it's usually a horse, but could be a zebra, but it's improbable to be a unicorn.
Well, thank you very much, everyone. I hope that was it.
Thank you so much. We really appreciate you guys doing that. That was really superb.
And Dan, we were saying at the beginning, we're already looking forward to Nashville. And,
Nashville would be awesome in October. I'm telling you. It'll be great.
Thank you, everybody.
Great.
All right.
Have a good day, everybody.
Terrific.